So we'll get started. So I just wanted to welcome everybody to the ICIS and the British Society of Breast Radiology presentation today on contrast-enhanced breast imaging state of the art. My name is Fiona Fennessy and I'm a fellow of the ICIS along with Sarah Vinnicombe. So today we're going to have presentations by Dr. Tamara Sauris and Dr. Sarah Vinnicombe. Next slide, Sarah. So we want to thank our corporate sponsors, Siemens Healthineers and Bracco. If you would like to sign up to our monthly e-newsletter, the ICIS monthly newsletter, you can click on this QR code and you get free news about our webinars, the online courses, and much of this is free. And then about articles published in cancer imaging. So it keeps you up to date with what's what in cancer imaging. We hope to see many of you at our first yearly meeting that's going to be held in Singapore. It's the first time it's in Asia. It's the ICIS meeting, which is taking place at the end, I think in 2 weeks from now, at the end of this month. And it's in association with the SGCR Wires. So the end of this month, if you would like to attend, it's the 27th to the 29th of September. And also just to keep you informed, if you go to the ICIS website, we do have an upcoming masterclass in oncologic whole body MRI. It's the second time this has been run in Stockholm in Sweden, and you have a vast array of very well-known faculty who are experts in oncologic whole body MR. And again, if you'd like to follow us on social media, these are our handles. So as a brief introduction, I'm going to introduce Dr. Sarah Vinnicombe, who's going to speak first. So Sarah is the lead breast radiologist and deputy director of screening in the Thirlstane Breast Centre, Gloucestershire NHS Foundation Trust. Before that, she was a clinical senior lecturer in breast imaging and consultant radiologist at the University of Dundee and the NHS Tayside from 2011 to 2013. She was the breast radiologist and director, the lead breast radiologist and director of breast screening at Barts and the London NHS Trust until 2011. Sarah is also the past president of the British Society of Breast Radiology and elected fellow of our society, the ICIS. She's a trustee of the Symposium Mammography and current chair of the conference organizing committee. Throughout her career, she's been very passionate about teaching and is a regular faculty member of ECR, ESOR, and RSNA. She currently sits on the advisory board of the UK National Breast Imaging Academy and is editor of e-learning breast MRI modules. Sarah is going to be joined today by Dr. Tamara Sauris, who is the clinical lead for breast imaging at Barts Health NHS Trust. She has been director of screening of Central and East London Breast Screening Unit and is now a professional clinical advisor for the screening program. Her interests lie in breast innovations and interventional breast techniques, and she works closely with the Centre for Experimental Cancer Medicine, where she is an honorary senior lecturer. Dr. Sauris has been PI for several studies at Barts and continues to develop research projects at Barts. She loves to teach and has set up a breast biopsy course and contrast mammography course at Barts, which she runs with her colleagues. So I am now going to pass you over to Dr. Sarah Vinnicombe, who will go first. So off you go, Sarah.
Thank you very much, Fiona. So I'm going to give you an update on contrast-enhanced breast MRI. These are my disclosures, which aren't relevant to this presentation. I'm going to whip through the new changes in the 6th edition of the BI-RADS lexicon. I'm going to talk about developments in contrast-enhanced MRI, and then discuss how they might have an impact on indications for breast MRI. So turning first to the BI-RADS lexicon, as you know, this is a structured reporting system, and the use of standardized descriptors and assessment categories means that we're much more consistent in our reporting and we can give succinct, consistent reviews. And this, of course, facilitates audit, peer review and benchmarking. Now, this is just a summary of everything that was covered in the 5th edition, which we've all been using until now. Remember that what we're looking for is significant enhancement in the form of a mass, a non-mass enhancement, or enhancing foci. And I'm not going to go through all these descriptors, but I will just walk you through the changes. So the first thing is that the structured clinical indications and use of comparison section has been updated, as has the section on acquisition parameters. But the main changes that we need to know about are in the lexicon. The plan is to remove the term focus altogether because the resolution of modern scanners is such that you should be able to determine whether a dominant focus is actually a small mass or a focal non-mass enhancement. The mass descriptors are updated, the lymph node section has been expanded, and some other descriptors have been added in. The other major change is in the reporting and assessment system, particularly to categories 4 and 6. Now, they haven't included diffusion-weighted imaging, which I think is a great shame, but they do at least reference the excellent USOBI position paper that was published a few years ago now. And this just shows you how good DWI can be if you have a good system. So here you see a myxoid fibroadenoma with the non-enhancing internal septations in the anterior right breast. You can see that there's a plateau curve, but you can actually appreciate the fibrous septations on the B850 image at the top right of your screen, and you can see the high ADC value with T2 shine through, really stunning images. Now, turning next to masses, as you know, a mass is a 3D space occupying lesion, and we need to consider the shape, the margin, and the internal enhancement. Now, one change is in the shape. So previously for oval, 1 or 2 gentle lobulations were allowed, but we now have a new term which is lobular, and you see in the bottom 2 images gentle lobulations in 2 different fibroadenomas. The term irregular for shape is maintained. And then thinking about the margin, obviously again we have circumscribed masses, we have non-circumscribed masses, but the term irregular has been replaced with uneven, like this mass here, probably because people were confusing the term irregular for shape and margin and spiculated as before. Internal enhancement hasn't changed very much at all, but we now have a new descriptor, which is the T2 signal intensity. Now this is qualitative, it's either hyperintense or not hyperintense. And so the thinking is that if you have a well-defined circumscribed T2 hyperintense mass, maybe with non-enhancing dark internal septations, you can assign it a BI-RADS 3 score. If you're in the US, it's likely to be a fibroadenoma, like the lesion in the bottom right of your screen. In the UK, we'd probably call that a BI-RADS 2. Non-mass enhancement hasn't changed very much. The important thing is obviously to correlate with all other imaging before you decide whether you are concerned about it. And as far as kinetics are concerned, remember that kinetics should not trump morphology. And the only change here is that the term initial phase has been replaced by peak phase. Now, lymph nodes, this section has been markedly expanded to include intramammary, axillary, and internal mammary nodes. If we're calling a node abnormal, it needs to be qualitative. So there should be features like asymmetric rounding, absence of hyla, but we're not meant to measure or use cortical thickness because many reactive nodes have a cortical thickness of 3 millimeters. You should record the number of abnormal nodes. As far as internal mammary nodes are concerned, they've used a cutoff of more than 5 millimeters. From my experience, actually, if you see an internal mammary node at all, you need to be quite concerned about it. Now, in terms of the assessment categories, category 3 hasn't changed very much, but the idea is that you should use that category in less than 5% of all exams and be very careful to assign a lesion a category 3 if it's a non-baseline study. Now, the big change is that MRI4 is subdivided into A, B, and C, just as for mammography and ultrasound, and the likelihood of malignancy in patients recalled for assessment is pretty similar, as you see from the chart. I think this is sensible, it makes audit more meaningful and facilitates radiological pathological correlation. And then considering assessment category 6, where we have a known cancer, there's been a change regarding how we label additional ipsilateral findings. So additional close findings are used for what we used to call satellite nodules that are within 2 centimeters of the known cancer and have a similar appearance. If we feel that it's not going to change clinical management, we can assign them category 6 and we don't need to do any more about it. On the other hand, if you have a lesion that's more than 2 centimeters away that would change management, then it can be classified as BI-RADS 4 or 5, depending on how concerned you are, and that clearly does need further evaluation. Now, the problem with the BI-RADS lexicon is that it doesn't include clinical decision rules, and this can make it challenging for inexperienced readers in particular. The Kaiser score, on the other hand, is a classification tree based on machine learning, which has been repeatedly validated. And all it uses are 5 discriminative objective criteria, and the final score is ranked by the probability of malignancy. And in this way, it's more objective. So this is what it looks like. If you've got something enhancing, is it spiculated or not? And then if it isn't, all you need to look at is the time intensity curve and whether or not the margins are irregular or circumscribed and the pattern of internal enhancement. Whereas if there is speculation, all you need to look at is the delayed phase enhancement and whether or not there's perifocal edema. If you have a lesion with a score less than 5, it is unlikely to be malignant. But you can modify the score by adding in whether or not there are suspicious microcalcifications on a mammogram and the ADC value, as you see. This study was done by Matthias Dietzel and Pascal Balzer a few years ago. It's a really nice study, multi-center study, and they used the ADC, the Kaiser score, and the Kaiser score modified, as I showed you on the previous slide, to look at benign malignant differentiation. And what they found was that the ADC and the Kaiser score were equally sensitive for cancers, but the specificity was higher with the Kaiser score. And this meant that in the theory, they could have significantly reduced the number of benign biopsies by 67%, way more than with the ADC alone. Now, what about contrast enhanced breast MRI? Why do we like it so much? Well, it's got the highest sensitivity for breast cancer of any test. It will identify mammographically occult lesions that are missed by combined mammography and ultrasound, and it'll detect cancers missed by DBT. And that's because the sensitivity depends on neoangiogenesis-related enhancement. And I really like this paper by Janice Sung. It's a few years old now, but you can see that as you go through from biologically insignificant low-grade DCIS all the way through to invasive cancers, the sensitivity of MRI shows in green goes up, whereas the sensitivity of mammography goes down with a corresponding increase in the number of interval cancers. Screening breast MRI detects aggressive cancers because enhancement reflects vascularity, and these are biologically significant lesions. Now, not only is there no ionizing radiation, of course, the accuracy is independent of breast density. Now, in terms of outcomes, we know that MRI screening will result in a stage shift, and it will reduce the rates of interval cancers, with the possible exception of BRCA1 carriers. But up until recently, we haven't been able to show definitively that there's been a mortality reduction. And a recent study published earlier this year was very helpful. This was a multi-center study with prospectively acquired data from 11 countries. And what they were able to show was that in BRCA1 mutation carriers, the hazard ratio for mortality in women undergoing regular MRI surveillance was reduced to 0.2, which is highly significant. But I think you'd all agree screening with MRI needs to be cheaper, more accessible, faster. And I would add in, it needs to be a lot easier to biopsy MRI-only detected lesions. So the drivers for abbreviated MRI are as follows. With shorter acquisitions and shorter reading times, you can increase your throughput, make it more available, you can lower the costs, and of course, it's going to be better tolerated by the patients. And this is really important because if you look at the ACRIN quadruple 6 study and the DENT study, both of these studies, even though they were nearly a decade apart, showed that 40% of women declined the offer of MRI, despite the fact that it was readily available at no cost, citing factors like claustrophobia. Now, if you could get over that, potentially you could offer an MRI to many more women in many more risk categories. The important thing to realize is that abbreviated MRI is an umbrella term focused on a specific clinical question. For example, is or isn't there a cancer in the breast? So conventional breast MRI may be the full diagnostic protocol with a DCE series, or multiparametric with the addition of a T2-weighted scan and diffusion-weighted imaging. And under the umbrella of abbreviated breast MRI, we have fast MRI, which is what Christiane Kuhl proposed. We have short protocol or abridged MRI, and we have non-contrast MRI. So here we have a schema of a standard full diagnostic protocol breast MRI, and you can see if you add in T2 and DWI, you can make it multiparametric. But DCE is the single most important sequence when it comes to cancer yield, and the early post-contrast period is the most useful. Why? Because that's when tumour to background contrast is at its greatest. So what Christiane Kuhl did, I can't believe it's nearly a decade ago now, was a prospective single-centre study with expert readers, 606 screening rounds in a little over 400 women. Now, some of them were normal, but most had a family or a personal history or dense breasts, and they all had a normal mammogram plus minus ultrasound beforehand. And this is what she did. She took one post-contrast acquisition from which she generated a subtracted series and a MIP. And you see an example of one such MIP from her study with a 4mm invasive ductal cancer. And these were the results. The acquisition time was reduced down to 3 minutes. The average reading time was under 30 seconds and under 3 seconds for the maximum intensity projection alone. The additional cancer yield was very high at 18 per 1,000, all detected in the first round. Most of these cancers were early stage, either DCIS or T1 tumours without nodal involvement. The MIP alone missed one cancer, but in 2/3 of cases, the exams were negative on the MIP, which could be read in just under 3 seconds. Now, since then, there has been a huge flurry of cases, as you see, from PubMed, from lots of countries, lots of patients. Let's look at some examples. Maximum intensity projection, mild background parenchymal enhancement, normal. Case 2, looks like there's something in the medial left breast, as you see. There is the corresponding subtracted series, and that was a grade 2 invasive lobular cancer. Case 3, bit more difficult because we've got more background parenchymal enhancement here, so you need to look at the series of subtracted images, and that was normal. Case 4, we've obviously got something going on in the left breast there, and this was a mantle radiotherapy patient with a 6mm invasive ductal cancer, grade 3. This one's a bit more challenging because not only is there a lot of background parenchymal enhancement, but the patient has moved too. So again, you need to look at the subtraction and look at the source data. And finally, example of a patient where there's clearly asymmetric regional non-mass enhancement in the left upper outer quadrant. There is the corresponding subtracted series, and that was 60mm of intermediate and high-grade DCIS. So turning to the diagnostic performance, bear in mind that many of the initial studies were retrospective with mixed screening and symptomatic populations, or with enriched test sets, or known cancers. So lots of sources of potential bias there, but nonetheless, most studies showed very little significant difference between an abbreviated and a full diagnostic protocol. The effect of the full protocol was to reduce the number of BIRADS3 lesions and increase diagnostic confidence. In those studies where more than one post-contrast sequence was used, that didn't have much effect on the cancer detection rate, but it did increase conspicuity of cancers and reader confidence. What about missed cancers? Inevitably, there are going to be some misses, and you won't be surprised to learn that these are usually small lesions, often non-mass enhancement. For example, DCIS and one invasive lobular cancer in the series from Mango et al. And a mucinous cancer in the series from Machetta. And this is one example from Mango's series where there was a 1.2cm non-mass enhancement, not seen at all on the MIP on your left, and partially obscured by a tissue marker on the raw and subtracted series. A couple of meta-analyses were published in 2021 in the same edition of ClinRad. This one looked at a mixture of screening and cohort studies. It found that, surprisingly, there was a low risk of bias, and it didn't show any significant difference in the sensitivity and specificity between the abbreviated and the full diagnostic protocols. But notice on the sensitivity, the very large confidence intervals, which reflects the fact that there were not many cancers. And a similar meta-analysis that we published, looking purely at the screening setting with no case control studies or enriched data sets, again showed no significant difference from the full diagnostic protocol, though assessment of the level of evidence was low. Do we know what the best protocol is? Well, the answer is really no, we don't. There's a lot of variability in sequences used. Nearly all series use one pre and one post contrast acquisition, i.e. Christian Kuhl's fast protocol, but many have added in 2 to 3 to 4 post contrast sequences. Other groups have used a Dixon technique, which has the advantage of improving fat suppression, and you don't need to do your manual pre-scans. And if you are in the States and you want to get ACR accreditation, you will need to add in a T2 weighted sequence, and both that and a diffusion weighted imaging sequence have been shown to increase specificity. Now, bear in mind that cost savings might not be as great as you would think. Sure, you save a lot of room hours, a lot of gradient time, massive reduction in the number of images, great for your pack storage, and significant reduction in reading times. But you've still got to prep the room, you've got to prep the patient, you have to pay a lot of attention to positioning and setup, and you've still got to generate the subtraction and the MIPS. So overall gains in patient throughput may not be as great as you would expect. But there are things you can do to improve efficiency, like make sure the patient arrives well in advance of the appointment, include your safety questionnaire with the appointment letter, make sure that everybody knows exactly what they're doing and run a session, and make sure that each member of the imaging team knows precisely what their role is. So we've talked about fast MRI, but there are other approaches. Ultra-fast MRI with accelerated acquisition through the whole breast, abridged MRI, as we've discussed, with the addition of a T2 weighted or diffusion weighted imaging series. As long as the acquisition is less than 10 minutes, it counts as abridged. And that's what they did for the ECOG-ACRIN 1141 study. And finally, non-contrast MRI, which sadly I'm not going to have time to talk about today, though it is a particular pet interest of mine. I think that's the subject of a whole other webinar. So looking at ultra-fast MRI, what this utilizes is accelerated acquisition up to 10 seconds through the whole breast, either through undersampling of K-space and view sharing, so Siemens twist, Philips 4D track, for example, or through compressed sensing with parallel imaging. And what you get is about 10 to 16 phases over 60 to 90 seconds, enabling assessment of the early wash-in kinetic curve. What's been shown is that cancers enhance earlier and quicker, and this can be assessed by metrics such as the time to enhancement after aortic enhancement and the maximum slope of enhancement. The advantage of this approach is that it minimizes background parenchymal enhancement, and so you get better benign malignant differentiation with higher specificity and intra-observer agreement. And I recommend to you, if you want to read more about it, a really nice review published in the Journal of Magnetic Resonance Imaging earlier this year. And here you see an example in red of a cancer with earlier time to enhancement and higher maximum slope than a benign lesion. A recent paper by Caratal looked at how long you need to carry on obtaining your ultra-fast series 4, and what they showed was that you need to carry it on beyond 67 seconds, but beyond that point, there's not much improvement in diagnostic performance. Now, you all know the indications for MRI, and I'm not going to go through all of these in detail, but what we need to think about, I think, is how indications might change with the use of an abbreviated protocol. And I think the main area where it's going to help is in screening of average risk women with dense breasts, moderate risk women with dense breasts, women with a personal history, either if they're young or if they've got dense breasts, and perhaps for women with high risk lesions of uncertain malignant potential, lesions with epithelial atypia. On the other hand, for other indications like lesion characterization and therapy response, my gut feeling is that probably we need a full diagnostic or a multi-parametric protocol. Now, turning to the dense breast, this is the ECOG-ACRIN 1141 study from Chris Comstock and Christian Kuhl, in which all the 1,400 women randomized got abbreviated MRI and DBT over 2 rounds. The protocol had to be less than 10 minutes, but they weren't too specific about it. And what they found was that for the 23 cancers, abbreviated MRI was way more sensitive than DBT. There were no interval cancers. As you might expect for the prevalent round, the specificity was lower for abbreviated MRI, and the biopsy rate was much higher with a lower PPV3. But Christian Kuhl presented the results of the incident round at ASCO the year before last, and as you might expect, the abnormal interpretation rate went down and the PPV3 went up, and still abbreviated MRI picked up more invasive cancers than DVT. The BRAID trial has just closed to recruitment in the UK, and this is the only prospective randomized controlled trial comparing standard of care, digital mammography, which remember is every 3 years in the UK, with either ABUS, contrast enhanced mammography, or abbreviated MRI. And the main outcome is the cancer detection rate at screening. And I want to share with you a couple of examples. This was the second patient that I recruited. She was recalled for 26 millimeters of BIRADS3 calcification, but before she underwent biopsy, she had an abbreviated MRI. This was acquired in under 4 minutes, and this was 80 centimeters of high-grade DCIS with 2 foci of invasive ductal cancer. And you could have no idea that that was there from her mammogram at all. Slightly more challenging case because there's more background parenchymal enhancement here, but again, you can see there's a dominant mass enhancement with a slightly hyperintense T2 correlate, and this was an 8 millimeter grade 2 invasive ductal cancer. Now, one important thing is the so-called prevalent effect, and there is very clear evidence for that. So if you look at outcomes over time, you can see in this very nice paper from Edmonds et al. That in subsequent rounds, there were fewer BIRADS3 lesions, the abnormal interpretation rate went down, and the PPV2 and 3 went up, with still a very respectable cancer detection rate. And this was confirmed in a very nice paper by Tamara's group, published recently. 24 studies, women with dense breasts, many were at higher than population risk. But in the large number of cases where there were negative mammograms, 288 cancers were detected by MRI. And the main thing that influenced the cancer detection rate was whether or not it was a prevalent screen or an incidence screen. But whereas it was estimable, they calculated that of every 3 cancers, 2 were detected by MRI, but not mammography or DBT. Another area where I think it could be used is in women with a personal history, and lots of studies are beginning to emerge about this. Now, most have been retrospective, but a one prospective randomized controlled trial showed a much, much higher cancer detection rate for abbreviated MRI. And though there were higher biopsy rates, the PPV3 was exactly the same. And if you want to make it even better, you could actually add in ultra-fast MRI to your abbreviated protocol to increase your specificity and your PPV1 further. And this is just one example from Kim et al. Where you see a little cancer that's been picked up there. And in retrospect, they could see it on the abbreviated MRI from the year before. Lesion characterization, I think this is not really a goer. And the reason for that is that you really need to look at morphology in a bit more detail. And this was confirmed by Kim et al. In a retrospective study who found that 15% of their cancers were missed by a fast abbreviated MRI protocol. And it's only on the later subtraction that you can clearly see that mass, for example, is spiculated. And then for local staging, this is another area where it might be highly effective. We already know it's superior to mammography and DBT. And in this retrospective study of a relatively small number of the pathology proven additional foci, the overall sensitivity of abbreviated MRI for the additional lesions in this multi-reader study was as high as 94%, not significantly different from the full diagnostic protocol. And here's one such example. You can see the index lesion at the back of the left breast with the short arrow, and on 2 successive subtracted images, you can see the additional foci anteriorly. And again, this is another area where the addition of an ultra-fast protocol, I think, would help. And similarly, if you add in diffusion-weighted imaging, it may perform better. And just finally, to finish up, it may have a role in response assessment, but this is an area where we need to do more research, because the literature to date suggests that we are most accurate in identifying pathological complete response and the extent of residual disease through a combination of diffusion-weighted imaging and late-phase contrast-enhanced MRI. But once more, this is an area where ultra-fast MRI definitely needs further study. So in conclusion then, I think The developments in the protocols could potentially greatly expand the range of indications for breast MRI, especially in screening, and this has great potential for greater equity of access. We definitely need more work on optimization and standardization, but I think the clinical question is going to dictate the precise protocol that we use, as I've indicated there. And finally, let us remember that we have to consider competing diagnostic tests, namely contrast-enhanced mammography. And with that, I'm going to close and I'm going to hand over to my good colleague and friend, Tamara.
Thank you, Sarah. Fantastic talk. So I'm going to give a little update on a number of aspects of contrast-enhanced mammography. So I'm going to also talk a little about the lexicon that's out there, and we should be using that in our structured reporting. A little on contrast mammography lesions where we don't have contrast guidance. How do we get around those problems? Talk a little about CEM in screening and surveillance and what's out there in the published data, how we incorporate it into symptomatic pathways, what's there for local staging, and evaluating response with MRI and contrast. And just to touch a little on AI, what's happening with AI in contrast mammography. So the contrast enhanced mammography lexicon was published as a supplement in 2022, and it takes you through how to report very clearly. And there are 2 or 3 sections that you need to include in your report. The first regards the low energy imaging. This is the equivalent of your standard mammogram and should be reported in exactly the same way as you would report a mammogram or refer to a diagnostic mammogram that has been performed recently that has the features that you're interested in. The recombined imaging is the subtracted, the contrast only imaging. And the first part of the report should describe any enhancement that correlates with the low energy. We also need to make sure that we're including in there the background parenchymal enhancement and how that looks and the pattern of it in a similar way to we would report with MRI. And the last section, which only some reports may need, is including a section on where contrast is seen without any correlate on the low energy imaging. So where you see enhancement alone without a mass, distortion or microcalcification. So
Tamara, sorry to interrupt. I don't think we can see your slides. So I'm really sorry.
Let me just go back to Can you see them now? Yes, I'm just going to go back one. So there are 3 sections: low energy, recombined imaging with a correlate with the low energy, and the recombined imaging alone. So where you've got enhancement without any correlate. So just to take you through a case, this is the low energy imaging. This is effectively a standard mammogram. This is a screening case where we can see a spiculate mass in the upper outer quadrant in the upper central in the right breast, with a background of a moderately dense pattern. There are some scattered microcalcifications, quite coarse, and some very fine benign ones, but the main lesion is on the right side. The recombined imaging, first of all, we're going to have a look at the background parenchymal pattern, and that is the enhancement pattern, and it's defined in exactly the same way as we would look at an MRI into 4 categories: minimal, mild, moderate and marked. And we also need to define whether that's symmetrical or asymmetric background enhancement. It can be quite difficult to gauge exactly how to describe this, and it takes a little bit of experience in seeing a few examples of this to know which category to put it in. But it literally just gives a flavour of the amount of, how well you're going to be able, the amount of confidence you're going to have when you see a separate enhancing lesion. So in this case, we've got some mild asymmetric enhancement in the left upper outer quadrant, but otherwise on a background of mild enhancement. Now, when we're looking at the recombined imaging, we're looking at what we can see that also correlates with the low energy imaging, so any mass, distortion or microcalcification. And as with MRI, we're looking for different assessments of the enhancement. First of all, correlating it with the lesion. Is it homogeneous, heterogeneous or rim enhancing? And what's the extent? Is it confined to the lesion or does it extend beyond? And also lesion conspicuity, which can be quite difficult, and it's categorized into low, moderate or high, and that's in relation to the background parenchymal enhancement. And again, that's eyeball, there's no curves, it's just experience and how it looks in terms of how brightly it shines out. So here we have in the lesion in the right breast, we've got a heterogeneous pattern within the lesion, and it clearly correlates with the distorting mass that we've seen. It enhances completely, but there is this sort of mottled heterogeneous pattern within. And I would regard this as high conspicuity because it's seen quite clearly, standing quite brightly out from the background parenchymal enhancement. The next thing to consider, and so you will need to toggle between the two to understand whether you've got exactly the right features, an enhancement correlating with the low energy imaging. More difficult is whether you and how you call any asymmetric background parenchymal enhancement. Is it just simply background enhancement or is it more suspicious? And the lexicon advises you to treat this with more suspicion. So looking at the lexicon, we're then there's a whole section to how to deal with areas of suspicious enhancement without a correlate on the low energy imaging. So is it a mass, is it non-mass enhancement or an enhancing asymmetry? And then we also will define the conspicuity level. So here we've got non-mass enhancement, it's focal, it's clumped, nodular, and it has a low conspicuity. And this would be suspicious and would be, I would recommend this was sampled in, we'll get to that, however which way you can. This is another case, it's a screening case, recall to assessment. We can see a dense irregular mass in the upper outer quadrant on the left. There is a clip there, you can see that, and that was placed under ultrasound. The lesion was seen under ultrasound, and this was a lobular cancer. It's difficult to size this lesion as there's quite a lot of what might be texture change around the mass, and with lobular cancers it's difficult to know exactly how much of that parenchyma is involved. It's clearly an M5 and a moderately dense background. So this patient couldn't tolerate an MRI, she was claustrophobic, so had a contrast mammogram. So this is the density we're looking at. And I'm just showing the CC imaging, the low energy and the recombined imaging side by side. We can see that there's the enhancing mass, and this correlates well with the known lesion. The background parenchymal enhancement is mild and symmetric. We can see a little bit in both breasts, but it's symmetric. So we're going to sort of just put that by the side. The enhancement does correlate to the mass that we've seen on the mammogram, but we're going to look at the lexicon to help guide us. The internal enhancement pattern is heterogeneous, but it does extend beyond the mass, extending anteriorly towards the nipple. And the conspicuity within the lesion is high, but there is some more moderate enhancement. It's a bit more subtle, extending anteriorly. And on the MLO view, you can see the amount of anterior extension of that mottled enhancement extending towards the nipple. So I've demonstrated there are a couple of cases where we've identified extra enhancement that doesn't have a clear correlate. And if you have a situation where you don't have contrast mammography, contrast enhanced guidance yet, there's only one vendor that has a license in the UK. And I think that the other vendors are coming online with their equipment. But in the meantime, I think we've all been struggling with how best to find these lesions. And again, you need to think about the context in which you're performing your contrast mammogram. Is it part of surveillance? Is it part of staging? If it is staging, then perhaps the protocol that you use might be tweaked to potentially give you more ammunition to help you if there are additional lesions identified. You need to correlate any suspicious enhancement with anything that you might be able to see on the low energy, whether that's a coarse calcification, whether it's an island of maybe normal looking glandular tissue, anything that you can use as a marker, a landmark to help you perform biopsy. And that may be a biopsy under tomosynthesis or stereotactically. First of all, I would always perform an ultrasound to see what's visible. We often find these lesions, a correlate for the lesion under ultrasound, and of course biopsy and clip that. And if we can't find anything that's useful, we have to proceed on to MR and MR biopsy. And again, it'll be great once we've got contrast enhanced biopsy widely available, because it is such a burden on a scanning time and the staffing related to that. For this case, this first case where there was this mottled non-mass enhancement seen in the upper outer quadrant, we looked again at the mammogram that had originally been called normal on that side. And you might see some tiny, and I mean tiny, specks of calcification that correlate with that area of enhancement. We would never have called this patient back for assessment of this calcification, but this helped us to then guide the biopsy. And in numerous cases where we've had what we would say was no correlate, no clear correlate of an abnormality on the low energy imaging, but enhancement seen, there are often clues, often even just one speck of calcium to help guide you. So let's have a look at what's happening with contrast in screening. Now, this is not currently embedded in our screening programme in the UK or in screening assessment, but I know that it's being evaluated, and I hope that it will be possible to use this as a tool in screening assessment soon. It has been used in trials, and as Sarah was describing BRAID, we have been using it to look at using this as a supplementary imaging tool amongst other imaging techniques to diagnose cancers in dense breasts. And it may well have benefits in other groups that have high risk, either related to density or to risk assessment, and excluding the very high risk, those patients who have BRCA. In the US, they're currently running a trial looking at DBT with CEM, the CMIS trial, that will help determine the accuracy and see if we can reduce false positive recalls with the addition of CEM. We already know there's a lot of evidence out there to say that CEM is of great value in the dense breast. We know that it overperforms when compared to mammography alone, and is able to utilize the angiogenesis that develops with cancers, and allows us to improve the diagnostic performance and cancer detection, and specifically in patients who have those very dense breast patterns. In the screening recall assessment, this may be, I think, in the UK, where we see this first in screening. In the Netherlands, the team there in Maastricht have done quite a lot of work looking at the performance of contrast in screening recalls there. They ran a trial looking at how well a group of radiologists with different levels of experience in CEM were able to report on studies, and what they found was there was a very high sensitivity and specificity and much higher area under the curve for CEM for all readers of all experiences compared with standard mammography. And that's useful to know that actually the learning curve is very steep. I think people will be able to pick up interpreting contrast mammography fairly quickly and probably much faster than reporting of MRI, which takes quite a lot of skill and experience. They have now published the trial, it's called the RACER trial, where they randomized women coming back from a screening recall into control, and a control arm where they performed the usual further mammographic views, DBT or ultrasound, and the intervention arm where they performed CEM. And they looked to see what the time to diagnosis was, if there were any adverse events, and how much intervention was involved in those two groups. And they found that the time to final diagnosis was comparable between the two. So there's certainly no inferiority with including CEM in the protocol. And really importantly, there were no serious adverse events, which is always a little bit of a worry for us, bringing contrast into areas where we might have less clinical staff. We have to be ready to resuscitate patients if necessary, but in their small group of two, was there were less patients who required FNA and cyst aspiration, and having a negative CEM significantly improved the negative predictive value there. So that is something that I hope we'll be bringing into the UK very soon. However, there are areas where, certainly in screening, there's an area around microcalcification where contrast may not be as useful to us. We know that the contrast is associated with angiogenesis, and it will be associated with invasive areas of disease and high-grade disease. And we hope that with calcification, there will be enhancements associated with the most suspicious areas where there might be invasion or high-grade disease. But a lack of enhancement does not necessarily exclude malignancy. A lot of the data that's been published doesn't discriminate between the different types of DCIS, high grade, intermediate and low grade. And with the current sort of treatment paradigms, we're moving towards less intervention and less treatment for those lower grades of DCIS. I think more data certainly is needed to see whether actually separating out more advanced disease, high-grade disease from lower grades might be useful to reduce treatment in those groups. But still, there's a lot of work to be done looking at the value of contrast mammography in evaluating microcalcification. We, in our department, looked at enhancement patterns. Would they be able to help predict pathology? And we looked at measuring with a signal intensity using an ROI, the area of enhancement, and then looking at dividing the lesions up into, once we knew the biology, into invasive, non-invasive and benign pathology, and found there was a significant difference in the signal intensity obtained with invasive diseases. We didn't have enough cases to separate out the non-invasive into high-grade, intermediate and low grade to try and identify whether there was a significant difference between. But you can see that there's I hate to say it, a trend that maybe some DCIS in that group is pushing the contrast levels higher and the ROI higher. And that's hoping to be published later this year. CEM and surveillance, and Sarah was talking about how we might use abbreviated MR in a huge, other range of scenarios that it isn't being used in currently. And CEM is also looking at these different groups. So in Australia and in America, they have been looking at looking at contrast enhanced mammography in patients who've had a previous history of breast cancer, and showing that there is increased cancer detection compared with standard either DVT or mammograms. In the Australian group, they had a reduction in interventions as well. And there's a trial that's published some interim results from Wendy Berg's group in the US, where they recruited just over 1,200 patients with a previous history of breast cancer. And they also identified, when adding in CEM into their surveillance, there was an increase in cancer detection in both years 1, much higher increase in levels of cancer detection, but also in years 2 and 3, and with a high proportion of those being invasive cancers, so not picking up the indolent, maybe biologically insignificant disease. What about in our symptomatic pathways? In our rapid assessment clinics or one-stop clinics, if we're to bring in contrast enhanced mammography into those pathways, we really need to have a very cohesive working group in our teams, from the surgeons, making sure they are triaging and have a very good clinical acumen for picking up P4 and 5 lesions, so that we can give those patients contrast up front and hopefully expedite their diagnostic pathway. But it's not without its challenges, both the workflow, the facility staffing, bringing that into the imaging arena. We need to engage everyone in that to make it work efficiently. What do we do about patients that we see that are younger? There really isn't a dose issue here. The dose that is delivered for a contrast mammogram is 30% higher than a mammogram, and given the increased diagnostic value that it brings in a suspicious scenario, we should be considering bringing this in. Preoperative staging, we know that there are several studies that show very good sensitivity and specificity for using CEM in upfront staging in breast cancer. But there are some limitations where we're looking at cases that are very deep in the breast, in difficult to assess places like the inframammary lesions. And we don't also have the benefit of looking at the axilla. And as Sarah said, we don't have the ability to look at internal mammary nodes, which we do with MRI. A study here by Ritziman and his team looked at contrast mammography versus MR, and they showed that it did have a slightly lower performance than MRI, but it may be valuable in many, an alternative in many clinical situations. But to exclude, as we would, those patients who are in the very high risk screening, and again, identified the limitations of using contrast mammography compared to MRI. And so if we're to stage using CEM instead of MRI, we have to choose our patients carefully. And just to touch on lobular cancer, there's been a little bit of a debate about whether it is effective and comparable with MRI. And this study shows by Mark Loeb's team, who does an awful lot of work looking into contrast mammography, that it is a potential alternative. And it has, although MR has a higher sensitivity, it has a slightly lower specificity, but there's no real significant difference between the two imaging modalities. So it could be used for invasive lobular cancer. Just to touch on implants, I think when CEM came into play, many people weren't imaging with implants. Maxine Jockerson's team in the US have done a comprehensive study looking at 198 cases of women with implants, where they had no complications apart from a patient who had one patient who had a vasovagal, and performing the contrast and under the Eklund and routine views was effective and also identified cancers. And this is one of the cancers from her paper, which shows a very subtle enhancement on the Eklund view. CEM in monitoring of neoadjuvant chemotherapy. Again, there have been a few studies now, and this systematic review was published a few years ago looking at this area, and showed that CEM was very had a bright future in evaluating the response for neoadjuvant chemotherapy. And it's an area that again is I think an easy win for us to reduce the amount of pressure on our scanners whilst not disservicing the patient and getting good outcomes. So again, looking at artificial intelligence, as you can imagine, it's an area that is prime for AI, with a fairly easy and compact data set to be analysed. And there have been several studies that have looked at algorithms to identify cancer from contrast mammograms. The main issues have been about the very small data sets that they've had to use. And that's an area that I think will expand, and I'm sure there'll be more trials looking at that, and more work trying to identify and have some software out there to help us look at the subtle stuff, the very difficult stuff that is problematic for us. And that's it. Quick shout out for our workshop that we've got in November. But thank you very much.
Thank you very much, Tamara. Fantastic run through. I can't actually, I just hope I'm looking in the correct Q&A bit, because I can't actually see any questions at all. I don't know if have you got any on your chat?
I can't see any either. Are they in? No.
No. Well, that's good. You're probably all feeling very hungry and feeling like you want some lunch, which is fair enough. I think, well, we'll just see if anybody types anything. But if you think about abbreviated MRI and contrast enhanced mammography, I mean, how do you think it's going to work out, Tamara? What are we going to use for what?
It's really difficult, and I think it's going to be very different in Europe to the UK. I really like abbreviated MR. I really do. I like contrast mammography, but I do find it hard. I find it hard to interpret it. And there's a lot of, is that something? The suspicious asymmetric enhancement is a problem. Yeah. Where would it be used? I think that we're going to use abbreviated MR in high-risk screening. I think that, and in potentially in the family history group, that more, yeah, the moderate risk. Yeah. I think things may change with surveillance. The surveillance patterns for patients who previously had breast cancer, I don't know if that's going to change after Mammo 50, and yeah, we'll have a rethink. Yes. And then, of course, I think BRAID has opened up an interesting issue. Yeah. We've got a long way to go to firstly identify and mark up dense screening patients in our system. Yeah. And then to invite them prospectively for supplementary imaging. Yeah. But I think that is the way to go.
Yes, well, I agree, but I agree with you also that in the UK we're some way off that. We have got some questions coming in now. I can see quite a lot. So a question about how many centres are using CEM in the UK, and is it mostly used in a symptomatic setting? I think the answer to that is, outside of a research trial setting, yes, it's just being used in the symptomatic setting. And the centre that has most experience is Nottingham, where they've been using it in the symptomatic clinics for a long time now. So if they have a woman with a clinically suspicious or obviously malignant finding on clinical examination, their first line test is going to be contrast enhanced mammography. Now let's just have a look. Yes, I think that's absolutely right. Until we get the results of the prospective studies defining in which groups we can use it, we're just not going to know the answer to those questions. There's been quite a lot of work done comparing the acceptability for patients between contrast enhanced mammography and MRI. And this is obviously a really, really important question. Yeah. And most studies to date have shown that women much prefer contrast enhanced mammo to an MRI. But to be fair, there haven't been many head-to-head comparisons that I'm aware of how people find an abbreviated MRI as opposed to a full diagnostic protocol. So I think the jury is out there for the moment, but that is clearly a major consideration. I'm trying in my centre to put forward a business case and get management of the trust to accept that in those women who have a clinically suspicious lesion and who are young and say under 70, which is a good cutoff because there you can assume that their EGFR is going to be acceptable, you do a contrast enhanced mammo as a one-off investigation. And for a healthcare setting like the NHS, which is so pressed, you could then perhaps obviate the need for a staging MRI. So that seems to me like a super way forward, and we shall see. So in answer to the question about in practice, are we using CEM mostly after MDM? I think it's used after MDM at the moment in those women who need an MRI, but who for whatever reason either can't tolerate or have a contraindication to an MRI. That's certainly how we're using it at the moment. And I think a lot of centres up and down the country are. So I hope that answers some of the questions. Couple here about asymmetric background parenchymal enhancement and whether it matters when you do contrast enhanced mammography in relation to the menstrual cycle. T, do you want to pick up those ones?
Well, there's not been a huge amount of data around this, and I think most centres don't need to time it with the cycle, but if you can, do. We did in Braid, but I'm not sure it really had that much effect. We did still see quite a bit of background enhancement. So I think the jury's out. I haven't seen anything that says it needs to be timed. And that's one of the benefits in some ways with compared to MRI. But saying that, we still see asymmetric enhancement that does need to be chased and followed. And it can be challenging to know when to stop. And that's the learning curve with CEM.
Yeah, I agree. And I certainly found that in Braid because I've been looking for MRIs for what feels like centuries. It can't really be centuries, but it certainly feels like that. But but for CEM, I've not been looking for them for so long. I and my colleagues, we are a centre which has a very low recall rate for screening and for our MRIs. And I rather suspect that we might have not recalled enough of CEM. So it'll be very interesting to see what happens when the Braid results come out. And yeah, that's potentially one advantage, of course, of an abbreviated MRI protocol. If you're acquiring your post-contrast information very early on, then maybe the background parenchymal enhancement is not going to be so much of a problem. But I certainly found during Braid, you know, I'm not sure if I should be admitting this or not actually, but for some of our cases where we really weren't sure what was going on and we'd recalled the patient for assessment after their Braid contrast enhanced mammogram, sometimes we ended up as part of the assessment doing a MRI.
Yes, and I think lots of us were doing that. Yeah. Because once we'd seen it, you can't unsee it and you have to resolve it. So
Well, absolutely,
yes,
absolutely. So just looking at most of the questions here, I think we've answered most of them. An interesting question here, which I think is very, very relevant to how we take things forwards, is about how whether radiographers can review and report CEM studies. Now, there's clearly a need for that. In a healthcare setting like the UK, where we have many radiographic screen readers, who, by the way, are just as good as radiologists, and who are starting and will be in the future reading, screening abbreviated MRIs, there's clearly a need for radiographic interpretation of CEM as well. So I'm absolutely sure that's going to be coming along in the next few years. And just finally, another really interesting question. I think we might have to draw it to a close after that. Will use of CEM be the poor man's MRI in low to middle income countries? It's an excellent question. As far as
I don't think it would be a bad thing. I mean, if they have
I
access
agree.
to it and they're getting better staging,
Yes.
yes, it's about availability and accessibility.
It is, isn't it? It depends where you set your bar, doesn't it? If you're looking at contrast enhanced mammography versus MRI or nothing, clearly a CEM is going to be a step over and above mammography. In terms of it being a poor man's MRI, there's been endless debates about that, haven't there, between proponents of it, like Mark Lobbers in particular, and people who, perhaps like me, think, well, actually, they love the multi-parametric information they get from a full diagnostic protocol. I think that the use case scenarios probably will end up being slightly different. But when you look at the massive global inequalities in access to good diagnostics for breast cancer, anything's got to be better than where we are at the moment. That's my view. So lovely. Thank you very much for all your questions. I really hope that has answered most of them. And thank you very much for taking time out from your lunch to join us. And I hope you found it useful.
Brilliant. Thank you, Sarah.
Bye.
Take care.